Starting your time.
Yeah,
Starting
yeah.
your time.
Yes, ma'am.
3 pages.
Ma'am, second page. नहीं चल रहा है। Yes, ma'am. Next page. Okay. Can I see this second
First
slide,
page.
please? Clinic name is not given.
Starting your 10 minutes time.
Hello, I'm Fakia, one of the doctors in the clinic today. May I confirm your name and age, please?
This is structure discussion. Okay, so let's have it as a SPT. This is a structure discussion. There
Okay,
are
okay,
only
okay.
sections.
Yeah,
Okay?
that's fine. Then I can do as a structured discussion.
Yeah.
Yeah.
So,
Hello, I'm Fakia, one of the exam candidates. I'm ready for the discussion.
okay. So, what information will you ask from the patient that will determine whether she is suitable for combined hormonal contraception?
So this is a case of 27-year-old who has come for the contraceptive advice. Especially, she wants a combined oral contraceptive pills. So I would, to proceed further, I'll take the targeted history to the relevant examination, and further management will be planned accordingly. So in the information, I'd like to know, rule out the contraindicate. First of all, I'd like to know why specifically she wants to take combined oral contraceptive pills. Then I would like to take history of all the contraindications for the combined contraceptive pills, especially if she has a family or a personal history of clots, migraine with aura, any cancers running in the family, and if she has uncontrolled hypertension. So these are the basic contraindications I'd like to know. And then smoking is also one of the risk factors which should be taken care of. And apart from that, I would like to know if she has any other medical conditions like diabetes or yeah, and basically diabetes, thyroid problem, and what is her BMI. High BMI is also one of the risk factors which should be considered when we are prescribing the hormonal contraceptive pills. And she already has 3 children, so I'd like to know the details of like whether like all vaginal deliveries, any unevent like outcome happened, and about her cervical smears, whether she's up to date with it or not, any other surgery she has, and yeah, how is the support at home, and like what is the future plans for the pregnancy, whether she would like to have any pregnancy in the future or not, or she's just trying to delay the pregnancy for the moment. And the menstrual history has been given that she had her menstrual period one a week back. So I would like to take detailed history about her periods also, whether they are regular or not, any intermenstrual bleeding, any after signposting, I'll ask her about the sexual history also, if she has any concerns with the sexual act, and any postcoital bleeding.
Okay. Uh, Now, what options in hormonal hormones you will offer this patient?
Mhm. Depending upon her risk factors, if at all the mentioned risk, like she has migraine with aura, or the risk of any clots, stroke, hemorrhage are there, then
No
the
history is
combined.
there. No such history is there.
Okay. Then the options available will be in the form of progesterone only pill, combined oral contraceptive pills, and we can give in the form of implant. She can get the Dimpa injection, which is Depo-Provera injection, and Mirena coil, copper coil, if she's ready for non-hormonal as well. And yeah, and
Okay.
if she
In
wants.
combined hormones, she would like to discuss the options. In combined hormones, do you have any options for her? Estrogen plus progesterone.
Yeah, in combined hormonal contraceptive pills, there can be the levonorgestrel with the estradiol. She can also get the recent ones is the drosperinone containing combined contraceptive pills with the estrogen. So we can discuss the.
Any rings, any patch? Have you heard about patches? Have you heard about
Yeah, yes, the patches are also available. So they need to be changed every week. And yeah, they are also available in the form of rings also. And yeah, these combined pills are available.
Okay,
Combined
so she is
contraceptive
keen
pills.
on patches. She is keen on patches. So what information you would like to share with her regarding the patch? How you are going to apply?
Mm-hmm. Yeah, for the patch application, it is important that it is changed every week. It has to be applied on the surface of the skin. It is completely attached to it. If it gets detached from it, then it should be properly placed, and the new patch should be applied if at all it is it is detached. Like this is what she'll do.
Okay. Uh, if at all the, I mean, for how long the extended patch will be there, and what if the patch will slip off? Do you have any
Yeah,
idea?
if the patch it should be applied for a week's time, and it is changed like in the first 3 weeks it is changed weekly. So if at all it slips, then like it depends. If it is slightly slipped, it can be reapplied. But if at all it comes off, then we need to reapply it as early as possible, and then the rest of the patches should be applied as per the previous protocol. And the date should not be changed. They should we stick to the date.
Okay. Okay, so that is what the questions are all about. Okay.
Mm-hmm. Okay, ma'am. Ma'am, I did not read this topic
Yeah,
actually.
that's the reason. Okay, so
That's
let's
yeah, yeah,
just go through the answer key. That's the
yeah,
reason
yeah.
I'm not going to give you detailed feedback.
Mm.
Very nicely, you introduced yourself. Then S bar is very important in this structure discussion task. The patient has been presented for combined oral contraceptive pills, a case of 27-year-old with para 3 living 3. So the history is very important here. The history, first thing what you wanted to know is about menstrual history. They had mentioned that the cycles are regular and the LMP was 1 week back. But whether there are any associated menstrual complaints, because this is going to give her additional benefit of contraceptive pills, that is non-hormonal benefits like PMS, heavy bleeding, dysmenorrhea, this will get resolved. Even PCOS will get resolved. Okay. So these are the
Mm.
benefits. So that history is very important. I would like to know about that. Smear history, unscheduled bleeding needs to be investigated. So the smear history is very important. Contraceptions, whether she has used any previous contraception, always ask this question, and how was her experience, and has she heard about larc. Okay, because we always promote larc, it is more effective, less failure rate. Okay, and once a month use only. So larc, did she heard about larc? Any contraindication to COC? Yes, you rightly mentioned that, because you need to identify whether it's a safe prescription. That is one of the important patient safety point. So what are the contraindication? BMI, smoking, migraine, VT, hypertension, hyperlipidemia, any drug enzymes. Okay, not contraindications, but then you will be more cautious. If the enzyme inducer therapy the patient is on, then you will be more cautious regarding the COC pills. Okay. Bariatric or gastric surgery, as it will minimizes the absorption. Okay, the absorption will not be proper. And person with personal or family history of cancer breast. Okay, these are the contraindication. Mm, Sexual history, pelvic inflammatory disease, they had mentioned. But for me, for offering COC, I don't find this history is very important. On examination is very important, blood pressure and BMI and the smear. These are the important points which you need to evaluate prior to offering a COC. The options in COC will be either pill, patch or ring. Okay. So pill will be taken. Means what are the options and pros of pills? The pills, yes. Pros, basically it's a combined hormonal pills. It is having a advantage of as a contraception and non-contraceptive advantage. In this case, nowadays there are this newer approach, that is tailored or period-free pill. Okay, so although it is not been recommended, but FSRH still recommend that tailored approach. Okay, so 90 days straight away the patient can continue and she may not get bleed. But the side effects are gastric side effect, and sometimes it's compliance. Like means remembering it daily, sometimes my patient might be forgetting. So that compliance is very important. Combined transdermal hormonal contraception, the patch weekly, only weekly changing is needed. Okay, so patch stays in the place for 1 week if applied properly, and then combined hormonal ring is an alternative taken monthly. Okay, compliance is very better. May forget to change ring, may interfere with sometimes sexual pleasure. Okay, if needed, we can also discuss the LARC. So one by one, you can go and discuss the options about LARC, its pros and cons. If you think you are having adequate time, POP less likely because it's having strict compliance is needed and scheduled bleeding is one of the major concerns. So that is one important point. Now, the question 3 is she opts for contraceptive patch. What you will be telling her about how to take it and precautions when it slips off and there is a delay in replacing. Okay, so this is all about patch. So the mechanism of action, it suppresses ovulation. How to use it? First, you have to introduce or apply it within the first 5 days, can be quick started at any time during the menstrual phase or during that month, but additional contraception for 1 week is important, which is very important pre ovulation. Advisable to use a backup method, condom for the first 7 days using patch, and if needed sometimes even you can ask to use emergency contraception also. Apply the patch to a clean and dry area skin where it cannot be rubbed off with your tight clothing, and it will be safe. It may not be removed, it will not be getting removed while changing your clothes also. So do not apply application should be either on stomach, buttock, upper back, upper outer arm. Do not place it on the breast. Make sure that, because hormones are directly releasing to the breast. Okay, so make sure the patch sticks, no makeup, cream, lotion, etc. should be applied. Skin where the patch is placed, press down firmly on the patch for 10 seconds, then applying and then when applying, make sure the edges stick well. The patch stays in the place for 1 week if applied properly, and you do not need to remove it while exercising, while showering. A new patch second week, the new patch third week, and then there will be a patch free week. Okay, so patch should be changed every week, max to max extension of 2 days. Okay, so additional extension of 2 days. So restart your next cycle from the fourth week. So this way you can continue the patch uses. What if it will be slipped off? Okay, what will it will be stripped off? So it depends upon the type, okay, the duration and amount of time the patch was slipped off, and the duration of the cycle, okay, whether it was first week, second week, or third week. So depending upon that, you may need additional protection for 1 week, and in few cases emergency contraception. Okay, so it has been given in different ways. So during week 1, patch has been off for 40. This is basically patch has been off for 24 hours. Okay, so whenever the patch will be off for 24 hours, so similar, it is something like missing out on one peel. You may not need to change it. Okay, you may not need to change it. You just reapply the same patch, and the new patch will be going according to the schedule. Okay, the new patch will be going according to the schedule, and this 3 cycles patch will be there. What if it will be off for 48 hours? Additional contraception. So if it is within first week, okay, if it is within 1 week, no change, reapply as soon as possible. Additional contraception you need to consider for 1 week. If during week 2 and week 3, along with apply a new patch as soon as possible. Keep same patch changing every day. Same patch change every day. Okay, so the next patch day will be the similar, whether you have applied it on day 3 or day 5, the next patch day will be same. Finish the cycle of patches, start a new cycle of 3 patches with no patch free week. Okay, so here there will not be any patch free week. If the patch is off more than 72 hours, then yes, additional precautions, emergency contraceptions, you may continue the patch without having a patch free week. Okay, with no patch free week. So this will be if the patch will be off for more than 3 days. So this is basically the missed peel or missed patch diagram from this FSRH guideline. Same guideline is again there. What if she forgets to take a patch to start a new cycle? So the patch can be kept for 9 days without having any issue. Okay, so she can very easily keep this patch for 9 days. After that, 9 to 12 days, apply a new patch, keep the same patch change day. Okay, so the patch should be applied on the same patch day. Finish the cycle of patches and start a new cycle of patch without a break. Patch 1 or 2 is on more than 12 days, apply a new patch, keep the same patch change day, finish the cycle of patches and start a new cycle of patches without a patch free week. Use EC as a backup. Okay, so if it is 1 or 2 more than 12 days, so always remember alternative contraception, emergency contraception, and keep the no patch free week, keep same patch change day, apply new patch. Okay, so this is all about a patch. Actually, little tedious type of structure discussion I thought of for this combined hormonal contraception in the form of patch. Less likely it will be asked, but still it's a since it's a exam, one should not be under prepared. It's always better to be over prepared. That is my philosophy, and that's the reason I have not skipped this task. Okay, I thought of taking this task. So information gathering, if we see domain-wise scoring, systematic approach, obtain detailed menstrual and sexual history is very important. I don't think sexual history is very important. Menstrual history is very important. Sexual history, STI history is not important, but dyspareunia history is important. Okay. Take detailed medical and surgical history, confirm reproductive history, ensure the previous contraception use, why the chosen method. Very nicely you had asked why she's keen on combined hormonal contraception. Review any investigation, previous record, initiate appropriate investigation, including BP and weight. Ensure patient safety point, ensure that the allergy is confirmed or excluded. Safe prescription, inform what to do with missed contraception. Ensure no contraindication to chosen method of contraception. Monitor the side effects for a chosen method. Safe contraceptive advice. Applied clinical knowledge, it's all from this FSRH guideline. It is not from NICE. Okay, it's from this FSRH guideline. We all know this guideline. Communication with colleague, less likely this will be means tested, but communication with GP, and contraceptive clinic whenever possible, or SRH clinic. Okay. Communication with patient, introduce self to the patient, explain your role, discuss various options, its pros and cons, provide information to a reasonable pace, enough detail to ensure understanding, and at the end, same time, encourage questions and provide answers. Summarize discussion and agreed upon the plan. Okay. So this is all about a patch. Any question anybody's having? All are silent.